Good evening, everybody. Welcome to Med School Tutors. What's this? It's our visual diagnosis seminar talking about images that you might see on the USMLE exams. My name is Joe Hansen, and my co-host is soon to be Dr. Moses Murdoch. I myself am a tutor with Med School Tutors. I've been working with this company for the last 4 years, and in that time frame, I've tutored a few hundred students for over 5,000 hours on camera like this. I've gotten very well acquainted with the USMLE and the kind of questions and images they throw into their exams. So hopefully this evening I can kind of help you guys to understand what we're looking for when we're taking these tests. Moses, do you want to introduce yourself a little bit?
Sure thing. Hi, everyone. I hope you all are staying safe with your physical distancing. My name is Moses. I'm a fourth-year medical student at the University of Pennsylvania. I just matched in internal medicine and really pumped to share some of the pearls that we have for you in terms of incorporating images. I've been a tutor with Med School Tutors for a couple of years, nowhere near Dr. Hansen's prolific output, but we're super excited to be here.
Yeah, absolutely. And great point that we're all stuck indoors right now. So perfect time for us to be sitting at our computer screens and looking at some radiology and images. All right, so to give you guys an idea of what we're going to be covering this evening, we're mainly going to be focused on looking at images that are going to be on the USMLE exams. Now, this is also transferable over to the convex exams as well for any of our DEO students that are in the audience this evening, so mainly looking at board exams overall. What we'll do is we'll look at 10 high-yield images. They're going to range between like radiology, blood stains, things of that nature to kind of give you an idea of what some of the high-yield images on the actual exams might look like, and then talk about the pathophysiology behind the diseases that are represented by them and how you would naturally bridge looking at an image to determine what the pathophysiology might look like. So briefly, just before we jump into the images themselves, I'll tell you a little about who Med School Tutors are. Basically, we're a collection of medical students and physicians who have done really, really well in the board exams, and now we want to tutor individually a bunch of students like yourself who are now preparing for the exams yourselves. It's one-to-one tutoring that we do primarily, where we meet with you over a webcam like this in a one-to-one environment and go over basically everything that could possibly be on anything in medical school, from basic biochemistry all the way up through step 2 CS. Obviously, this evening we'll be focusing primarily on stuff revolving around like step 1. However, we can tutor really anything in medical school. We've got tons of residents like Moses, who's about to enter into internal medicine, and attendings who have done really, really well on their tests. And so we'd be happy to work with you individually if you feel like an individual tutor might be useful for you in the future. Enough about us, however. Moses, do you want to tell us a little bit about generally what we'll be talking about tonight and some basic tips for looking at images on the USMLE?
Sure thing. So the first point that I want to make, really big picture, 30,000-foot view, is that the images and as well as other multimedia that can show up in a question stem are part of a larger set of information that you receive. And so you, as the test taker, are integrating the demographics, the history of present illness, the physical exam that is written out in front of you, and integrating in the images. These images range from histology slides, gross pathology, radiology, and it can be really easy to see something that you don't recognize and have that kind of take a hit on your confidence. And what we hope to convey to you here today is not only some high-yield pearls, but also this idea that even if you don't know exactly what's going on in an image, you can always rely on the other information that's presented to you to make a really educated guess and maximize your chance to get the right answer.
That's an excellent point. And I'll highlight the fact that generally speaking, the vignette in the question is going to give you the vast majority of the material that you're going to need to actually answer the question correctly. This evening, that's not exactly the approach that we'll be taking. We'll be focusing primarily on looking at the images and discussing what we see in them and how we could bridge that into an answer on the exam. But it's really worth pointing out that when it comes to images, auscultation questions, graphs, and diagrams, generally speaking, the kind of clinical background and vignette that you're seeing on those are going to be really helpful towards driving you to the answer. And in many cases, you almost don't even need to utilize some of the multimedia that they put into the exam. However, gaining expertise in both the multimedia utilization and looking at the vignettes together guarantees that you'll have success when you run into questions that have multiple components. Generally speaking, the images that they will give you on the USMLE will be extremely pathognomonic for a specific condition. It would be fantastically rare to run across a question that has multiple pathologies in it because they want you to be able to recognize the single pathology that they're looking for. There's usually not going to be somebody presenting with two distinct pathophysiologies. There's one thing that they're looking for in the image, and they want you to see that as well. So anticipate seeing high yield classical findings and not zebra type findings. That being said, if you try to look at an image and you don't recognize necessarily what's going on there and it looks totally foreign, the main idea is not to panic. Now, ideally, everybody going into the USMLE exam will have prepared a lot for it, studied a lot of material. And so what I like to tell students that I work with individually is that by the time you go into the test, if you've done most of UWorld or hopefully all of UWorld and looked at all of first aid at some point in your medical career at this point, you've seen everything. And so if something shows up on the exam, whether it's radiology, peripheral smear, a diagram or graph, and you don't recognize it, it's probably because it's not something that you're immediately supposed to recognize. It's probably not something super easy. And so you can work around that by utilizing other context clues that are present in the vignette or other components of the question. You do not need to be an expert radiologist in order to take step 1 or even step 2 CK. That is completely not necessary. In fact, for step 1 and level 1, you likely haven't had any formal education in radiology whatsoever. And yet here you are answering questions about x-rays and CT scans and MRIs. You got to do the best you can. However, recognize that this is not a skill that you're going to master at home alone. It's going to take a lot of clinical practice in order to get a sense of what really matters on these things. So for that reason, don't anticipate that you're going to perfect these skills, but try to develop them as best as you can nonetheless. Did I miss anything there, Moses? Anything else to add about big picture stuff?
I really love all the points that you made. I will just throw in one pearl, which is that if you're looking at radiology and you have no idea what you're looking for, symmetry is your friend. In general, if something looks different on one side than the other side of an image, that's something to focus in on and ask yourself if there's an abnormality there. We'll get into the other pearls along the way, but looking for big picture patterns can also often direct your gaze in the right direction.
Absolutely. One more thing I'll mention just about what we're doing this evening before we jump into our first image is that you might see Moses or myself look off to the side or seem or appear distracted during our conversation this evening. If you have any questions that you want to send to us, we can go ahead and answer those directly while we're talking. And so you might notice that I'm responding to one of your colleagues by looking off in the other direction. I apologize. I'm trying not to be rude and I'm not ignoring you guys, but I'm talking individually to somebody if I do that or if Moses does that. So sorry in advance for seeming a little distracted throughout our conversation this evening. All right, so without further ado then, let's go ahead and jump into taking a look at some images. Moses, you want to go ahead and take us through this image here?
Absolutely. So in general, we would love for all of you participating to do that active learning. We know that active learning is a key part in encoding memory. And so what I'd love for you all to do is take a couple of seconds, 10, 15 seconds, look at this image, and then in the chat, if you can throw out your differential, the name of the finding that we're seeing here, and then we can discuss. And I'm already seeing some folks in the chat throwing out the classic description for this skin finding. Absolutely. So what we're seeing here are the lower extremities, and these erythematous they look bumpy and bilateral. And if we can go to the next slide, I think it'll surprise no one that this is Erythema Nodosum. And folks in the chat, you guys are so ahead of the game, not only giving us the name of this pathognomonic skin finding, but also some of the differential. So I want to sort of elevate this above just memorizing a list of diseases and just point out that a lot of these diseases have some things in common. They're all inflammatory in nature in terms of their high yield associations. Notice that they fall into autoimmune or infectious. And within the infectious category, it tends to be atypical like mycobacteria or fungal diseases. And often these are the same sorts of diseases that lead to granulomatous disease, like Crohn's disease, as well as TB, sarcoid, things that you all might have heard of. So that's phenomenal. The underlying lesion here is inflammatory. It is a paniculitis. And if you see this on an exam, you should really be thinking of something inflammatory, just like the things that we put it in the high yield associations. Joe, anything to add?
No, you nailed that. Very well done. Only thing I would say is that in terms of looking at this image and guessing right off the bat what the diagnosis might be that underlies this and causes this to happen. The USMLE exams have a strong predilection towards showing this for inflammatory bowel disease. And so I would be leaning towards GI problems in terms of autoimmune inflammation if I saw this picture right off the bat. However, that being said, all of these high yield associations are fair game on the exam, so we can't fixate on one particular diagnosis. We'd have to utilize the clinical vignette in order to determine what the actual underlying diagnosis would be here. Great job, Moses. I'll go ahead and take the lead on our next one here. So a little bit of a different approach on this one. Instead of looking at a plain picture of a patient coming in, now we've got some radiology. The first thing that we always want to do when we look at a radiographic image is determine the modality that we're looking at. In this particular case, we can probably make the guess of what we're looking at. Does anybody want to throw in the chat, like what type of image this is? All right, got a couple coming in. Oh, we got people diagnosing the disease already too. Great job, everybody. So this is a CT scan. And the way that we know that is namely because number one, it's a relatively low resolution image. You can tell that it's kind of fuzzy and kind of grainy. Also, bones are bright white. Calcium shows up very well on CT imagery as a bright white picture, as does blood, which we might see later on, although we don't see that so much in this image. And so this CT scan that we're looking at here is showing us that we're looking at kind of an abdominal CT. So first, we notice that it's a CT exam. Number two, we're looking that we're in the abdomen. We can see a couple of major organs here. Number one, as somebody has already shouted out in chat, we can see our liver, which is located on the patient's right side. Keep in mind when we look at images like this, we are looking as though we're looking from the feet up at the patient. So imagine that you're kind of sitting in front of the CT scanner and kind of peering at the patient from their feet up when we're making these slices, which means that the left side of the image, where my hand is here, is the right side of the patient. And of course, as far as big solid organs go, the liver is going to be the one that's located on the right side. And then on the other side, we'll have our spleen. So we've identified a couple of our pieces of basic anatomy so far. And then from there, we might identify like a couple of other things, like maybe a blood vessel right here, the aorta, and then alternatively, we can notice that we have the spine back here. Otherwise, though, there's really one big thing in the middle of the picture here. And this liver picture that we're looking at here is going to kind of violate the first rule that Moses discussed before. Granted, the liver is not really a symmetrical organ. However, you can tell that is not uniform. And I would expect the liver to be uniform because it's made up of a bunch of tiny hepatic lobules over and over and over again. I really shouldn't see these kind of cheetah spots that I'm seeing all over this liver in this case. So these little hypodense areas that we're looking at here probably are irregular. And so the next thing that we would want to do is try to decide, well, why would I have random spots in the liver that look irregular? And looking at what some people have said in the chat here, we're noticing that, all right, looks like maybe our diagnosis here could be something like metastatic cancer. In particular, the liver receives all of its blood flow from the intestinal tract for the most part. And so as a result, colon cancer is probably going to be the most likely thing that we're going to see that's going to throw mets to the liver. That being said, you could, of course, end up seeing the pancreas, the stomach throwing metastases over here as well. We don't really know where it might have come from here unless we have other symptoms in this patient. We need the vignette to see a little bit more. Anything to add to that, Moses?
The only other thing is just a little bit of a pearl. I love this idea of the portal vein bringing these foci of metastases into the liver. Primary cancers of the liver, like a hepatocellular carcinoma, often get their blood supply through the hepatic artery as opposed to the portal vein. And so even fancier types of imaging that is not relevant here, but just to point out that typically you would expect more of a single mass versus multiple masses, as you've already pointed out.
Awesome. And I'll also add to that, if this were a primary cancer, it would be a little bit more likely that it would be solitary rather than multiple mutations throughout the liver, since it would be a little less likely for it to metastasize to its own organ. Not impossible, but nevertheless, multiple spots throughout an organ usually tend to indicate that something is scattered or spread throughout it. So awesome. Thanks for the assist. Let's go ahead and move on to our next image. Moses, going to go ahead and give this one a crack.
Yeah, absolutely. So whenever you see an image, I love, Joe, what you did earlier about kind of orienting yourself to the image. And in this case, we want to first decide, where are we in the body? This looks like a camera. And so if you think about, you folks are way too fast for me, cameras in terms of scopes are typically introduced either through the mouth in terms of an upper endoscopy, or looking at the lower digestive tract in terms of a colonoscopy, a sigmoidoscopy, etc. And as folks in the chat have already pointed out, this looks like it's a scope from above, so an EGD. And I'm seeing folks talk about a couple of diagnoses. If we were just to describe the lesion, we expect the tissue in the esophagus to be kind of a healthy pink, to be fairly uniform in color without ulceration. And what we're seeing here, it looks like it's almost an erosion of the superficial layer here. It looks angrier, a darker, beefier red. And so if we go to the next slide, I think consistent with what you all were thinking, this is Barrett's esophagus. It is an adaptation of the normal tissue of the lower esophagus to the acidic environment that is kind of creeping up from the stomach into the lower esophagus. And initially, this isn't that big of a problem. Obviously, you want to treat the patient symptomatically, but the more frightening development that could happen is that metaplasia then proceeds into a dysplasia, leading to a neoplastic transformation of the tissue in the lower esophagus. And that's why in the very bottom there, you're seeing that this is an esophageal adenocarcinoma. So let's take this up even another level. What would it look like if this was scarier? If folks start having problems swallowing, right? If they're having dysphagia, maybe initially for solids, but then to liquids, then that would be an alarm sign, maybe weight loss as well, that this has progressed into something more serious. For the chat, just because y'all are so good, what if the patient had, name a disease in the chat where it is equal for liquids as it is for solids in terms of dysphagia? And then I'll stop talking so Joe can take us to the next image. Oh, I love it. Someone's pointing out achalasia. So you're thinking of motility disorders that are not discriminating between the consistency of the food that is going down. And you might imagine that other things that affect the muscles and perhaps the nerves of the esophagus would lead to that sort of a result. All right, I'll shut up now. Joe, take it away.
Awesome job, Moses. I was going to jump in and mention alarm findings, but you got there before I could. So awesome work. All right, we'll go ahead and move on to our next image then. Changing things up a little bit. Now we're looking at a peripheral smear. And one thing we want to do to orient the image, as Moses was talking about before, is kind of identify, generally speaking, what we're supposed to be looking for on a peripheral smear and whether this aligns with our expectations. Now, obviously, there's something in the middle of the image that calls to our attention immediately that's abnormal here, but I will point out it's probably worthwhile glancing. So what do I usually look for when I'm looking at red blood cells? We would usually want to be looking for something like, you know, microcytic versus macrocytic size of the cells. Difficult to do on a peripheral smear alone without actually getting the values for that, but you can look at the relative sizes of the red blood cells. Is there any anisocytosis or poikilocytosis? Any changes in size and shape of red blood cells? Are there any or histologies like cell or schistocytes located on this image? Do we have the normal kind of hypochromic center that we have to our red blood cells, or do we have spherocytes that are uniform throughout? In this case, nothing really jumps out. You might make the argument that there's a couple cells that look uniform and spherocytic in the periphery of the image, but otherwise there's really one main thing in the middle, and people have already gotten ahead of me and answered in the chat. We see that we have what's called a rouleau formation that's located in the middle of this image. So one step forward, can anybody tell me, number one, what causes rouleau formation, and number two, what the diagnosis might be in this case? I've already got some answers from a couple people. So diagnosis here could end up being something like multiple myeloma, but can anybody tell me in the chat why multiple myeloma? Why something like that would end up causing rouleau formation? What is it about that disease that would cause this change in this image? All right, and we've got a couple of good answers here already. Too many immunoglobulins, or alternatively, increased protein in the blood in general. So excellent. We did our best to find other pathology here, but all we really ended up seeing was the rouleau formation, and we know that that means hyperproteinemia. Now, that could mean that we have multiple myeloma, which is a very common way to get hyperproteinemia. But any other condition that has lots and lots of protein in the blood, or in particular, lots of immunoglobulins in the blood, like somebody who's got Waldenstrom's macroglobulinemia or some other disorder along those lines, will also demonstrate this poker chip stacking to the red blood cells that we see in the middle image here. Granted, it could be other causes of hyperproteinemia that cause this on the exam, but for all intents and purposes, step one most likely is going to give us multiple myeloma as our diagnosis here. So because you guys absolutely nailed it already, I'm going to ask a further question here. What would be maybe the diagnostic test I would use to demonstrate that we have too many immunoglobulins in this case? Can anybody tell me that? I think I might have stumped it, Moses. Oh, somebody got it.
Oh,
Okay,
they're coming through.
Right when I thought I got you guys. All right, so excellent. A lot of people put it up. We're going to do protein electrophoresis or serum protein electrophoresis, which is abbreviated SPEP or SPEP. The idea being we're looking specifically to see if there's lots of protein in the blood, but what a protein electrophoresis can do is it can tell you that there's a lot of gamma globulins in the blood, which is the specific weight and size of proteins that usually lend themselves to immunoglobulins. So excellent job, everybody. This is a pathognomonic finding in this case, where reading the image really took a second back seat to just seeing the pathology in the middle. Was there anything that I missed on there, Moses, or that you would want to add?
That's perfect. I think just to put this in the context of the clinical vignette, remember the crab mnemonic, where you might see hypercalcemia along with this, renal failure. You can get Benz-Jones proteinuria, where the high levels of proteins gum up the works in the kidney and lead to renal failure. You can have anemia that's associated with this disease, and then the bone lesions. Often a skeletal scan or some other radiographic study is performed to assess for osteolytic lesions.
Completely agree. I want to add one more thing onto that now that you mentioned it. The crab mnemonic is particularly frustrating for a lot of students because it doesn't automatically jump out to them very clearly. If you look at the question stem for a question about multiple myeloma, you'll find that the patient will complain of bone pain as their chief complaint, and then they will give you 45 lab values. And as you look through them, you'll identify that calcium is one of them that's abnormal, there's an anemia in there, and there's a mildly elevated creatinine. A good way to kind of organize yourself in a question like this, it didn't give you the classical image in this case, but instead relied on the kind of diagnosis by utilizing the kind of mnemonic there, would be to write out the abnormalities that you are finding as you go through a question on your scratch paper. That way you can kind of organize your thoughts and have all of the different distinct components of the disease that you need to bring together and build together to make the diagnosis in one location. Usually students will miss the forest for the trees on this diagnosis because it's not immediately obvious when you see hypercalcemia. You're like, oh, obviously multiple myeloma. Usually you have to put together all those individual components, which are spread out through many, many lab values that they try to obfuscate the question with. Thanks, Moses. I'll go ahead and hand over to the next image here and let you take over.
Absolutely. So we're staying right there in the peripheral blood smear. And in the chat, if you could call out the what we're actually seeing in the peripheral blood smear, and then if you can think of the diagnosis. Okay, perfect. I'm seeing some answers coming through. So again, remember that when you're looking at the peripheral blood smear, in general, there are three different types of blood elements that you're looking at. You're looking at the red blood cells, and Joe already gave us a great layout of the different things we might see there. Platelets, I would say that very infrequently will you be diagnosing platelet disorders on a step exam based on a peripheral smear. But you know, in the real world, you can assess the amount of platelets on your peripheral smear, and then it's the white count. And with the white count, what you're really looking for is the amount of cells and then dysplasias, or other pathognomonic findings. I'm seeing a lot of folks point out the fact that we're seeing our rods. So I'll ask you a step further and say, okay, what are our rods composed of? So if anyone in the chat can put in what those our rods are composed of. I'm seeing several people, perfect. So this is myeloperoxidase. And then what about a particular subtype of AML? I'm looking for the chromosomal translocation that is classically seen in this disease. And again, y'all are so on top of this. This is the 1517 translocation, the PML RAR alpha translocation. And what's the drug that we can use to target that specific alteration. Beautiful. Vitamin A, all trans retinoic acid. So y'all are doing my job for me. This is phenomenal. I'll point out that not all AMLs have hour rods, but for the purposes of step 1, if you see them, that is a huge, huge clue that you're dealing with an acute leukemia. I saw in the chat some folks mentioning smudge cells, which are classically seen in CLL. There, you wouldn't expect to see that super high NC ratio. You wouldn't see hour rods, and it would have more of a crushed appearance as opposed to what we're seeing in this case. But that's a great thought. Also, CLL, just like AML, tends to affect older individuals. CLL really a disease of the elderly. So I'll leave it up to Joe to kind of hit anything that I missed so far.
No, I think you nailed absolutely everything. The only thing that I might add on to there, just to disambiguate a bit, is to say that not all AML has the 1517 translocation. A subtype of AML has the 1517 translocation. So it could be there and it could not be there, which is one thing that I found a lot of students tend to struggle with, is they will anticipate that it's like having the Philadelphia chromosome or any of the translocations that you'll see in lymphomas, which are necessary for the diagnosis of the condition. Not so much necessary here. All right, great job overall. Without further ado then, if you have nothing else, I'll go ahead and jump to our next one. All right here, so for our next picture here, we have an actual x-ray. So we're finally at like our plain film radiology here. And as we've been doing up until now, it's a good idea to orient ourselves to the picture and get a sense of what we're looking at, where we're at, and what we're supposed to be seeing in this picture. So first thing I'll point out is that number 1, we want to be looking for the kind of penetration of the image. When we talk about penetration, the idea with a plain film x-ray is that the x-rays are shooting through the individual and hitting the film behind them. Somewhat unintuitively, the black areas on the image are the ones where the x-rays have penetrated through the patient, which means places that have lots of air, namely the lung, are going to allow transmission of more x-rays and more black. Therefore, things that don't allow transmission of x-rays are going to appear very bright or white on the image, which is why bones show up so clearly on x-rays predominantly. So we look at this image to look at the penetration, and the idea is you can kind of turn up the gain in terms of like how well the x-rays are penetrating through the person. Usually what you will want to see is that you can clearly see the lung fields, you can clearly see the cardiac silhouette, and if you really look, you can clearly see the spine behind the heart as well. A well-penetrated image, like the one that we're seeing here, you can see all of those things. Generally speaking, it'd be really hard to identify pathology if the image is too bright or too dark. The other thing that we want to look for here is symmetry. Like Moses had mentioned before, symmetry helps us to identify pathology, but here it helps us to identify that the image is appropriately rotated for us. What we want to see is that the clavicles that we see here are basically parallel to one another and also the same length. If you take an image where the person is rotated, you'll end up seeing one clavicle looking a lot longer, the other clavicle based on the position of the patient. They look well rotated here, they look well penetrated, and now as we make our way through, we can start looking at some basic anatomy. I can see a clear spot in the middle of the image where the patient has their trachea, and it looks like it's dead center. I don't have any deviation of that trachea. I can see the actual main bronchi, branching off and going to each lung here. In addition to that, I can see that I have some pretty clear lung fields with some nice costophrenic angles between the diaphragm and the ribs, indicating that it doesn't look like there's a lot of fluid pooling on either side here. And the heart looks like it's just about the right size and shape in this case, less than 50% of the total width of the image that we're looking at. So altogether, I've got a pretty good image that I'm looking at, but there's one thing that really stands out here, and yep, you guys are already starting to nail it. The big thing that kind of shows up on this image is that the hilum, the area where we have kind of a bunch of lymph nodes and also the main pulmonary arteries, is pretty white in this image, which means there's a lot of tissue there. And so we usually call this finding hilar lymphadenopathy. Can somebody throw out what diagnosis hilar lymphadenopathy might be associated with, especially if we were looking at a 30-year-old African-American female, for instance, as our kind of demographic background? All right, we're getting some answers in. And everybody's nailing it now with background. You can see how the vignette really helped to bring out the diagnosis of an image. The answer is sarcoidosis. Excellent job, everybody. Can anybody tell me then what I would see on biopsy of these lungs if I were to take a kind of like microscopic picture here. All right, so quite a few great answers here, and the answer is granulomas, specifically non-caseating granulomas. Keep in mind that the caseating subtype is what we would see with necrosis of lung tissue, which would be more associated with somebody developing tuberculosis. I want to point out just as a little feature here, granulomas are our body's way of kind of walling off things that they can't get rid of. For instance, the place that you would normally see a granuloma outside of pathology like this would be if we have a small component of silk suture or glass or sand that was located under a person's skin. Because macrophages and inflammatory cells cannot destroy those materials, the best thing they can do is kind of wall them off and create a ball of tissue around those things. This ball of tissue they develop is called a granuloma, which basically is evidence that we failed to destroy something that we tried to destroy, that was a foreign invasion of the body. They're looking at, for instance, these non-casing granulomas that we're seeing are over-inflammation of the body, basically seeing that we're developing too many granulomas and an autoimmune attack on our own tissue. Can anybody tell me what laboratory finding we might end up seeing here if we looked at the electrolytes for the patient? All right, nailing it. So hypercalcemia is the main thing we would end up seeing. And in conjunction with what we've discussed so far, the reason we would end up seeing that calcium elevation is because there is a lot of enzyme to convert vitamin D to its active form in the membranes of the macrophages that make up the granulomas that we're seeing in the lung tissue here. So it all kind of comes together that we have these non-casing granulomas with lots of macrophages. The macrophages are converting vitamin D to its active form. Vitamin D's main role is going to be involved in calcium homeostasis, and we're going to develop hypercalcemia as a result of that. Moses, anything that I've missed so far that you'd want to throw in there or add?
You nailed so much of that. The only thing I would say is the enzyme 1-alpha hydroxylase within the macrophages is linked with the hypercalcemia, and so that might come up as a high yield enzyme to know.
Absolutely, thanks for the assist. All right, I'll go ahead and toss it back over to you to take a look at our next picture then, now that we've kind of gone over that x-ray. Go for it.
Perfect. So this is round 2 of cross-sectional imaging. Joe already gave us a primer on the orientation of the image, how substances in the body that are very dense show up as white, areas that are less dense, air-filled, show up as black. So first of all, where on the body are we? In the chat, throw out kind of the general body region where we're at. So right, what we're seeing, just to orient everybody, very top, we're seeing that sternum. That's the bright white bone at the top. In the back, we see a vertebral body, and we see the ribs kind of enclosing this entire space. Smack dab in the middle, we see the heart and its associated great vessels. All right, and then all of that dark is the lung. And with all these types of imaging, you can switch or modulate the gain on the system to highlight different features. And so what diagnosis would you make based on this particular image on the screen? And I'm already seeing a few people commenting here. Yeah, so you're seeing this hypodense thing, essentially, in the pulmonary vasculature. And this would be, if I told you that the history was, you know, a 50-year-old gentleman with partially treated colorectal cancer who's just come back from an 18-hour flight, plus this picture, it screams pulmonary embolism. Exactly. What vital signs would you expect with a pulmonary embolism of this size? Throw out what some vitals that you might find. Yep, so I'm seeing tachycardia, exactly. The heart is trying to push blood past this obstruction. You might see some tachypnea, the person isn't ventilating and oxygenating. Perfect. And you know, if it's a really bad PE, you might see low blood pressures as well. So let's go to the next slide, which I think summarizes a lot of these findings. And you all nailed this presentation. Notice that tachycardia is underlined and it has some stars next to it. There's a good reason for this. sinus tachycardia is really ominous in internal medicine because it tells you that there's something outside of the heart, potentially, that you should be diagnosing and treating, right? It could be something as uncomfortable but benign as just pain that you might want to treat. It might be an infection, or in the case of a pulmonary embolism, it could be something fatal that could lead to your patient's demise. Pleuritic chest pain is interesting because it's one of those descriptors that really helps you understand chest pain as a presenting symptom. When I think of pleuritic, my way of thinking about this is that this is the rubbing of two surfaces. It's the heart and the abdomen, the heart and the mediastinum, right? Or the anterior chest wall. And so things like pericarditis, things like PE, things that inflame the pleura can all cause this pleuritic chest pain. Perfect. And what we were just seeing was the CT pulmonary angiography. You'll notice in the bottom that we're mentioning a finding on electrocardiogram, which is the S1Q3T3 abnormality. Let me tell you that usually your diagnosis of a PE will not hinge on you identifying this pattern on an EKG, but it is something nice to look for. And I think a picture is worth 1,000 words. So in the next slide, we actually highlight really nicely what we mean. So in lead 1, you see S waves. And in lead 3, you see that Q wave and then the inverted T. Again, I don't think this is what's gonna, nail the diagnosis for you, but if you do see it, it's another tool increasing your probability of thinking that this is a PE. Anything that I missed, Joe?
Oh, definitely didn't miss anything. I would simply add and kind of add to what you had said before about how maybe it's not necessary to know an S1Q3T3 to make this diagnosis, but this is kind of dovetailing with what we said at the beginning of our presentation this evening, in that we don't necessarily always have to utilize everything that's given to us in terms of the diagrams, images, or multimedia in a question in order to make the diagnosis. A finding like this, if it were to show up on a step 1 question, would be totally ancillary and vestigial. We wouldn't need to understand this in order to answer the question, but if we do understand it, we basically get the question for free at that point. So it's nice to know, but at the same time, if anybody's looking at this EKG and thinking, I don't even know what EKGs are supposed to look like, let alone what an S1Q3T3 looks like at this point, don't worry, you can still do quite well on the exam and answer a question about this specific pathology without having this particular knowledge. So don't stress too much if we're kind of giving you guys tachycardia of your own as you're looking at these images. So let's go ahead and move on to our next picture. So this one kind of, again, dovetails with the previous one in that we just discussed looking at CT imagery and specifically CT imagery of the thorax. You'll notice that this image is at a very slightly different plane. So we can end up seeing a couple major structures in the middle. So we've already got some people making the diagnosis here, but before we get there, can anybody tell me what the 2 structures are that I'm looking at right here in the middle of the image and the other one that looks kind of like a wishbone right here? Are these solid organs or something else? All right, so we got a really good answer. The answer is vessels. We're looking at vessels here. And in particular, we can actually see the patient's sternum located at the interior portion of the image. And so I can kind of judge that if I'm looking at major vessels that are located where the sternum is located, and now we've got some great answers coming into the chat, we're most likely looking at the aorta and the pulmonary trunk, divulging into the 2 major pulmonary arteries that we're seeing here. A lot of people will describe this looking like a pair of pants. I can't really say I've ever really seen that myself. It looks more like a wishbone to me. Nevertheless, the pulmonary arteries are this kind of pair of pants that we have in the middle. Nevertheless, there's one major pathognomonic finding that we have in the center of this image. A couple of people have already said it, but go ahead and throw it out there in the chat. What are we looking at here in the aorta? All right, very good. And I'm seeing a lot of people say that we have the double barrel lumen that we're seeing here, which is usually going to be indicative of an aortic dissection. I want to throw out there for a couple of the students who are kind of like sending out answers, really appreciate you participating. Aortic aneurysm are a little bit different than aortic dissections. While an aneurysm can dissect, it's not the same thing as having a dissection because an aneurysm is a billowing of the wall. What we're seeing here really is more of a pseudoaneurysm in this case, as opposed to a true aneurysm. So the idea here is we have an injection. I know that I have this double barrel or shotgun barrel appearance that we can see in the middle of the image for the aorta proper. In particular, anybody tell me any kind of like clinical findings or vital sign findings that might be weird if I took the patient's blood pressure in this case? Very good. So I'm seeing a lot of people saying that we have differential blood pressures. Sorry, guys, I'm going to disappear for a minute here. My audio connection is starting a little bit. Hopefully this will help to preserve the kind of bit rate of my audio as opposed to the video. I'm still here. I haven't disappeared. So great answer. What we could end up seeing here is get differential blood pressures in the two arms. And one way that we could end up seeing that is because the dissection can track all the way up to the kind of subclavian trunk that we have on the right side of the image. In particular, the main thing that we're seeing in this picture is that we have a false lumen to the aorta and a true lumen, blood that is collecting in one portion of the aorta that's not moving and becoming more static and more hypodense on the image, and blood that is more dense, that is actual arterial flow. One major thing that can lead to the development of this condition is hypertension, because hypertension can cause the dissection to occur by just simply pushing too hard on the aortic wall. One thing that I want to point out is that a major finding that you can end up seeing with an aortic dissection is pain that radiates to the patient's back. And a couple of people have already mentioned that in this case. Can anybody say in chat anything else that would cause pain in the abdomen or chest that radiates to the back? Very good. Everybody's saying, or a lot of people are saying, pancreatitis, and that is correct. We can end up seeing the pancreatitis or even a ruptured AAA, an abdominal aorta, that could lead to pain that radiates to the back. And the main reason for that is that these are retroperitoneal structures. And for that reason, the pain that you experience in the abdomen in those cases can be referred to the back because they are so close to the nerves that are located back there. So anybody who comes in with chest pain or abdominal pain that radiates to the back, you're immediately thinking aortic disease or pancreatic disease as two major things. So that's a clinical facet that will jump out to us immediately. The other thing that we're going to end up seeing that's really clear here on plain radiography is going to be a widened mediastinum. If we come back to what we had seen in our chest x-ray before and use those same rules, we look here and maybe this image is not quite as good as at penetration as our previous one is. I'm having a kind of hard time seeing where like the spine might be located here. Nevertheless, the thing that jumps out to us as being very abnormal in this case is that the shape of the aorta here above the heart is a little too big. This aortic knob that we see here is a billowing out of the aorta, which is usually going to be indicative that there's blood collecting in the wall of the aorta in this case. And so this is our classical appearance of aortic dissection. The widened mediastinum is describing the fact that the structures above the heart are a little bit wider and thicker than we would have anticipated normally. Anything I missed throughout that entire thing, Moses? Anything to add about a widened mediastinum or aortic dissection in general?
That was all phenomenal. The only pearl I'll add is the emergent causes of chest pain. I think of three systems. So the first is cardiac, and there are the two A's and the two T's of emergent chest pain: aortic dissection, ACS or infarction, and the two T's, tamponade and Takotsubo stress cardiomyopathy. From a pulmonary perspective, we've already seen a pulmonary embolism. Another one would be a tension pneumothorax, so that's the second P. And then in terms of GI, I saw someone earlier had pointed out impaction or perforation of the esophagus as an emergency that you really want to identify. And you combine the clinical clues plus your radiography to point you in one direction or another. So that was great. And I'm happy to take the next image.
All right, well, let's go ahead and jump right into it. Thanks, man.
Perfect. So here we have, let's just say this is an older gentleman in his 60s. You are in the room with him. You just finished chatting. You're about to begin the physical exam. You start with the head and you go down. What do you notice? And this is one of those cases where symmetry could be your friend to identify something pathologic. And y'all are just way too way too fast. Yeah, so what I'm seeing is on the left side of the patient, remember that we're flipping our orientation because we're facing the patient head on as if we're having a conversation. Thank you, Joe, for highlighting that node. And so in general, I kind of want to have you guys think about differential. So when you see a lymph node enlarged like that, what general classes of disease do you think of? I'm seeing a lot of GI cancer. Yeah, cancers from the abdomen. Yeah, and someone else is saying immune. I will tell you that on step one, if you see this classic, people have been putting it on in the chat, Virchow's node, you should be really suspicious for malignancy. And where would that malignancy come from? What would be the source? So a GI source, a couple of people are saying, yeah, that's totally fair. To address a couple of other things, you know, I actually, as a med student, find it really hard to assess jugular venous pressure. So whenever you see jugular venous pressure, if it's elevated, what you're really thinking is that the preload to the right side of the heart is high. And that would be a clue that you're having some form of congestion, like a CHF exacerbation, for instance. It would be tough to see that on an image, a still image like this, because in the clinical context, you're often looking for the waveform in the patient's neck to identify the vein from the carotid artery. I'll stop there because I'm going internal medicine. I can get really excited about these physical exam things, but I really love those ideas coming through in the chat. So let's go on to the next slide, where we summarize some of the findings here. Perfect. So again, you're suspicious for malignancy. Y'all are absolutely crushing it in the chat. Stomach cancer is a common culprit. And Virchow was a prolific individual. So he has all sorts of things named after him. Virchow's triad is stasis, hypercoagulability, and endothelial damage, right? In the chat, can just throw out some hypercoagulable states. Okay, so pregnancy. There are genetic disorders like factor V Leiden, malignancy. Absolutely, there's some autoimmune scenarios, antiphospholipid syndrome that can give you a lot of clotting, both arterially and venously. Yep, autoimmune disease like lupus, often associated with phospholipid syndrome. Beautiful. Yeah, medications such as OCPs lead to a slightly higher level of hypercoagulability. Perfect. So you all already have this data bank in your head of things to think about in terms of risk factors for DVT, PE, and other sorts of hypercoagulability. Joe, take it away.
All right, man, you killed that one. I really don't have anything else that I can possibly add to that. So excellent discussion of the hypercoagulability on top of that. I'm going to disappear my webcam here just to make sure that my audio stays stable. Sorry, guys, for the technical difficulties. But in return, I'll give you a bonus triple image for our last picture here, looking at 3 different things at once. Now, all of these are brain images that we're looking at, but again, I have to reinforce the first thing that we do when we look at these images is identify the modality that we are looking at. And it turns out that in all 3 of these cases, the thing that we are utilizing is CT imagery. It's tempting to think that we're looking at an MRI in this case, but one thing that really throws us that we're looking at a CT is, again, the low resolution of the image. I cannot see every nook and cranny in the brain. I can't really see every gyrus and sulcus here. Furthermore, I can also see that the bone, the skull itself, is bright white. Something, given that CT scans are made of many, many different x-rays at once, x-rays really reflect off bone really well. Furthermore, blood can be very bright on CT scan in neuroimaging, and we can see here that we have 3 different images with collections of bright stuff in the middle of the cranium, indicating that we have bleeds. Now, these are 3 different pathologies, and some people have already diagnosed all 3, so I'm very impressed with you guys this evening. Excellent job. Well, let's go one step at a time here. Looking at the first image that we have here, this bleed that we have here is convex in nature, and it looks like it's pushing the brain pretty substantially. Can anybody tell me which artery was likely lacerated to cause this type of bleed? I've got two answers that I'm seeing here, and I want to clarify. Middle meningeal is the one that we're looking for here. Keep in mind that the middle meningeal is a branch of the external carotid. For those who said middle cerebral artery, that would be an artery that's coming off of the internal carotid in the middle of the brain. A bleed there would lead more to a subarachnoid hemorrhage, which we'll get to soon. So the picture that we're looking at here is an epidural hematoma. Thank you to everybody who kind of like threw that diagnosis out there right away, killing it. And for the epidural hematoma in particular, what we're looking at here is that this is usually an arterial bleed. The reason that's important to classify this as arterial is because the high pressure of the arterial blood is literally pushing the brain out of the way. Now, the important thing to notice here is that we are going to end up fixing the bleed into two different locations here, because what we're seeing here is that the periosteum of the bone is being lifted. Basically, we're seeing that the dura mater is being pushed and lifted off of the bone here and anchored at suture locations. This type of bleed cannot spread to the rest of the brain, but it can tent outwards and push the brain nonetheless, causing significant pathology. The main thing that we're worried about with an epidural hematoma is that this can cause herniation, which can end up killing the patient. We're really worried about mortality with these bleeds because herniating the brain is basically a death sentence. One of the major things that we end up seeing here is that patients will experience what's called a lucid interval. They will have a head injury that causes a concussion, and then following that, they will awaken and then start to accumulate blood in this epidural space until it compresses their brain enough to knock them out for good. It is important that these patients quickly are brought to a hospital so a burr hole can be placed to drain that blood. The fortunate thing is, if they do receive therapy, there's almost no morbidity long term. And I want to clarify, mortality means it will kill the patient, and this will. But if you fix it, you will not have any morbidity, and morbidity is when patients have disability or long-term injury. Fortunately, in this condition, if it's treated quickly, there will be no long-term consequences. Going to our other bleeds here, I want to skip over to our kind of far image on the right here to draw a parallel to what we just saw there. This one is more of a concave bleed that we see going along an entire hemisphere. And many people have already said that this looks like a subdural hematoma that we're seeing here. Can anybody tell me where the blood is coming from? What vessels have been ligated or ruptured here? Doing great as always. Multiple people saying veins, specifically the bridging veins that are located between the brain and the dural venous sinuses, which are fixed in place. If somebody has a rapid injury or rapid deceleration injury, they can end up tearing these bridging veins and causing this subdural hemorrhage. Can anybody tell me what age of patient we're typically looking at here? Young, middle, old? Yep, typically looking at elderly patients when we look at somebody who's experiencing a subdural hematoma. The idea being that elderly patients generally are going to have some degree of cerebral atrophy, and that cerebral atrophy increases the span or distance that these bridging veins have to travel before they reach the dural venous sinuses, which means there's more space to snap these guys. Now, the problem that we have with this one is that it is really hard to remove this blood. Stopping all of these little veins from bleeding is nearly impossible to do. And so draining all of this can be really difficult. It's not like an epidural hematoma where you just fix it and it's gone. This one is less likely to kill patients, so the mortality is low, but the morbidity is very high. Individuals who have this, elderly individuals, might experience chronic neurological difficulties after this occurs the first time. Bonus question, what other kinds of patients, oh, some people have already named it, but apart from the old, who else ends up experiencing subdural hematomas? Can anybody throw that out there in the chat? Seen a couple good answers here. Children, specifically shaken babies, and we'll come back to that idea in just a second. The last image we have here is the middle picture. Can anybody tell me in chat what is our diagnosis here, just based on the picture alone? Seeing a lot of good ones here. And yes, this is a subarachnoid hemorrhage that we're seeing here. Can anybody tell me what likely popped or ruptured to cause this condition? Ooh, I got a lot of good answers here. So aneurysm, specifically berry aneurysm. Now, where that aneurysm was, we're not sure. A couple people named specific arteries like the PCA or the MCA. Unclear, but there was a berry aneurysm somewhere. And classically, Barry aneurysms are more likely to occur in the anterior cerebral arteries at the anterior communicating artery, but they could be located anywhere throughout the major arteries of the circle of Willis. So excellent answer. I'll point out that subarachnoid hemorrhages usually are going to be associated with people who already have a Barry aneurysm. So we're thinking something along the lines of autosomal dominant polycystic kidney disease or Ehlers-Danlos syndrome. Generally speaking, the thing that we can do for these patients is to give them medication that prevents vasoconstriction, specifically calcium channel blockers, and namely nimodipine is the favorite that we'll end up using for this one because it prevents the nearby arteries from vasospasming. Somewhat surprisingly, I'm not so worried about the pressure buildup in the subarachnoid space in this case as I was with like the epidural or subdural hematomas. Instead, I'm worried about the blood itself causing nearby blood vessels to become irritated and vasoconstrict, which can actually lead to further ischemic strokes following a subarachnoid hemorrhage. And we can prevent that hopefully by using a medication like nimodipine. I think that nails the 3 images that we have here, but Moses, do you have anything to add to those 3?
That was phenomenal. Really, really great. I believe that the only other thing that I believe we have a slide for, so if we advance, is thinking about the 2 bleeds that are pathognomonic for child abuse. And Joe, you already brought up the pearl that subdural hematomas can be a consequence of shaken baby syndrome. There's another place where you can have bleeds. Y'all are so fast. I'm already seeing it in the chat. I'll wait a couple moments for other folks to chime in. Right. So it's retinal hemorrhages, right? So this is a really unfortunate situation. Subdural hematomas, retinal hemorrhages can be seen in cases of child abuse. Perfect. So let's see if there's any additional pearls on the slide. We have an image here. You can see that dark blood in the retina. Beautiful. Yeah. So again, the clinical history is really important here. So the epidural, you have fast bleeding. It's arterial, middle meningeal. Remember to look out for the sort of the biphasic element of the history where like you have that lucid interval in these brain bleeds. That can be a clue. But other than that, you all did a phenomenal job at correlating imaging, histology, as well as just skin findings and physical exam findings to the clinical vignettes here as well. Joe, anything to add?
Just as we transition here, this was the last image that we were going to look at this evening. While you guys are sending us questions, I'll just go ahead and wrap up by telling you a little bit more about Med School Tutors and what we do. Again, this is a tutoring company. Our main focus is working one-on-one with students over the internet. Generally speaking, the majority of our work is helping students to work towards board exams, but we do help students on coursework exams and clinical shelf exams and basically anything that you can be tested on in medical school. Part of what we will do with students is sit down and actually work through material like Moses and I did with you guys this evening, focusing on a student's weaknesses in order to kind of help them to develop robust knowledge in everything regarding step 1, step 2, or any other exam we're working towards. We also help students to determine what resources are best utilized for them to get the best score they can possibly get. And we help them develop study schedules and kind of itineraries of things that they would want to accomplish before they reach their test. Furthermore, we also usually will communicate with students via email in between sessions to answer any questions they have about content, study schedule, or otherwise. In addition to that, if you are just looking for some help to establish a plan for step 1 or step 2 or any other exam, we can also field a tutor to work with you for a very brief time to kind of help you do that.
Points. I really want to highlight that our emails are open. You can contact us via phone. Often you all will find yourself under unique circumstances. We're all sort of under unique circumstances right now. And we're happy to chat with you.
So we really, truly appreciate your time, the effort that you put in this evening. As Moses said, it's a kind of wild time, truly unprecedented time that we're in right now. That being said, given that we're stuck indoors, pretty good time to study. So hopefully we helped you a little bit in your path to taking step or level exams. We wish you the absolute best of luck as you prepare for these tests, and we hope you all earn very high scores. So once again, thank you for joining us this evening. We'll see you guys on the other side. Have a great night.
Best of luck, everyone. Bye.